Welcome to the Point of Medicine podcast, brought to you by LearnNeuralTherapy.com. Doctors Ann Hill and Alana Gurvich team up to take a deep dive into the art and science of healing. This podcast explores cutting-edge approaches to the autonomic nervous system and its role in organizing fascia for optimal health. Each episode features conversations with leading clinicians who are pushing the boundaries of medicine, uncovering new insights, and transforming patient care. Join us as we bridge tradition and innovation to expand what's possible in modern healing. Just a reminder, this podcast is for educational and entertainment purposes only and not intended as medical advice. Please consult your healthcare provider before making any changes to your healthcare plan. Join us and let's jump into the next episode.
Hey, everybody. Thanks again for joining us for the Point of Medicine podcast. Today, we are really excited to be interviewing Dr. Peretz. I'm going to go ahead and do your little bio right now. Dr. Peretz maintained an acupuncture practice for 8 years before entering osteopathic medical school, where he graduated in 1999. And since then, he sought to integrate Eastern and Western approaches to his musculoskeletal practice, and it's called Advanced Pain Solutions. So we'll have that info on that after we're done here. And he is practicing out of Reading, Connecticut, and he seeks to meld acupuncture, osteopathy, prolotherapy, and neural therapy. And he's also the past president of the North American Academy of Neural Therapy, which is our big neurotherapy association here in the United States. Okay, so thanks for joining us today, Perry. Really appreciate your time.
Thanks for making the North American Academy sound big.
Well, it is a big thing.
It's a big thing for a small number of people.
Yes. Well, hopefully not for too long. That's kind of our point here, is we want to really help educate practitioners and patients about how useful and helpful these practices can be for their health, and to bring in, especially for treating chronic pain patients and things like that.
Can you tell us how you even got started in medicine? Give us a little bit of your backstory about
How much time do you have?
Days. It's the internet. It can go on forever.
Okay. I have a kid in college right now, and I made a point of taking him to a party with a bunch of my college friends. We went around the circle asking them what they had studied in college and what they were doing now. And the correlation was about 20%, that there was anything that they had studied previously that brought them where they were. So I went to college thinking that I wanted to get into public broadcasting, and I was a communications major because that was the only thing that could fit all that stuff under one umbrella. And I was really into theater arts, and I was fascinated by the idea that if you inherited a different posture or worked your body in a certain way, that would convey a very different character on stage or in any other medium. One of my good friends at the time was interested in Rolfing. Rolfing was kind of brand new in the mid-70s. So we went to see this Rolfing demonstration, and I was just kind of amazed because this guy was kind of bulldozing through connective tissue and finding, emotional bombs buried in there, kind of like doing some kind of construction project that has to be halted for an an archaeological dig, right? So you have something that you had not expected just kind of show up. And that was really cool, but I found it kind of scary because I thought, oh, well, if you learn to do this work, then you kind of have to be a psychologist to figure out how to work someone through their trauma that you just uncovered, because you don't know what you're dealing with. So we thought that was really fascinating, but it was kind of unruly. We didn't know what to expect. So I had a friend who was on the tennis team, and she messed up her ankle really badly. She tore a bunch of ligaments, and she was like a regional doubles champion, and she was a very serious player. So she went to the sports medicine clinic at the University Hospital, and they said, oh, you're so lucky you've just gotten here on time, because we have newly perfected our knee replacement surgery. And what we'll do is we'll give you a new knee, and we'll take the ligaments from your knee and we'll implant them in your ankle so that, we don't have to use pig ligaments, and you don't have to have immune suppressive drugs, and, it'll just be perfect. Now, you'll never play tennis again, but if you follow our rehab program, we'll have you running in a straight line in 6 or 8 months. And she's like 23 years old. She's an athlete. She's never had a big problem before. And she looked at them and she said, I don't know what I'm going to do, but I am not doing that. There's nothing wrong with my knee. And they say, oh, yeah, we know that. We're only using it as a harvest site for your ligaments. She was just floored. So, among the people that she knew at the time, there was a woman who was studying acupuncture in England because that was the link between our school and the Worsley School in England. And she said, look, acupuncture is not legal in Pennsylvania, but if you want to drive to Maryland, they just legalized it there, and you can get acupuncture treatment in Baltimore. So she thought, well, what do I have to lose? So she started driving to Baltimore getting treatment. She called me 2 months later. She said, you got to listen to this. She said, not only am I back on the court when they told me that I would never play again, but my acupuncturist has shown me things that I didn't think were possible. This model of health is more comprehensive than anything that we understand in Western terms because it's not reductionistic and it doesn't separate mind and body. In fact, my acupuncturist has clued me into her thinking that the reason my ankle was vulnerable in the first place was because I'd been so angry with my parents. We're talking about the gallbladder meridian. And at that point, my head kind of tilted. He's like, wait a minute, you're telling me there's a system out there that can not only help heal people physically, but can help identify these emotions at that precisely? And she said, I didn't believe it either, but I'm just flabbergasted. So I said, I want to learn that. And she said, funny, I just enrolled as a student in the acupuncture program. I'm going to start in May. Why don't you join me? So I wasn't ready. I was a couple years behind her academically. I said, you know what? I think I'll get there eventually. She said, I'll give you 3 years. 3 years later, I was in the program and started studying. So if you're still with me, I'm on chapter 1, right? So acupuncture school was a fantastic foundation, right? They gave me so many different ways to understand how to build rapport with patients, how to um, how to relate to them in any number of different ways that would be very different, as you know, from a typical Western perspective. And I was so glad for that foundation. But I wasn't really that great at doing some of the things that were required. For instance, all of the diagnostic approaches in Eastern medicine are generally very subtle and vague. We were supposed to listen for the sound of the voice. We were supposed to listen or to look at the color on the face and read the pulses and all that. And I found myself in a position of trying to convince myself that I knew what I was doing. And the only thing that I could trust was my hands on soft tissues because I had done quite a bit of massage by that time. And if I could do a treatment and I could feel the tissues shift under my hands, then I knew I had something. But other than that, did I really think that I had brought the small intestine pulse up? I don't know. Did I really see the color of the change in the face? Did I really hear that weeping voice? I don't know. Was that a shouting voice? It was quite confounding in many ways. So I anchored myself in the things that I knew how to do. And at the time, there was a naturopath who had just moved from Oregon. He'd gone to the national school, and he got an acupuncture license in Maryland because they didn't have licenses for naturopath. So he was practicing Bethesda and he was introducing us to his practice. So of course, I'm very interested in the main thing, which is how did you learn what points to treat? Were you a principle guy? Are you a 5-element guy? Tell me a little bit more. And he says, oh, I don't pay any attention to any of that. I'm like, what do you mean? As well, I just ask the body what points it wants me to treat. I said, what? How do you do that? So I do it all by muscle testing. This was roughly 1990, something like that. I'd been practicing for about 3 years at that point. So I said, show me what you do. And he says, okay. So here we go. I think I'm going to need to treat the spleen meridian. So my muscle test is, I just go right up the meridian, 1, 2, 3, 4, spleen 4. Okay, spleen 4, spleen 5, spleen 6, spleen 7, 8, spleen 9. So I'm going to treat spleen 4 and spleen 9. That's my treatment. I thought, wow, like that's so crazy. It just might work. Right. So I decided that I would try to do that in my practice. I immediately went back, started muscle testing everything. I muscle tested like what socks I should put on in the morning. I went completely nuts because I needed to figure out if this way of approaching the work would teach me something. And I was more than rewarded for having the effort. Now, it took 2 years of doing that on a daily basis before I had enough confidence to make that my approach, that my main approach to addressing a patient. But once I got there, I never looked back because it was so rewarding. I would find things that I didn't know were there otherwise, then I would see the difference it would make. So this is actually setting a course for neurotherapy because I was using the body in question, the connective tissue matrix as my template for getting into the remedy, right? So now I'm in medical school, and that's another story. So before I started medical school, I was working with this anesthesiologist. Oh, that's the other part of it. So all this time, I was in my 20s when I got my acupuncture license. Not really well established as an adult, didn't understand how to do business. I was very much into teaching people about the work. I wanted them to understand what I was doing, which couldn't have been farther from their interest. They just wanted to get rid of their pain. They didn't care how I did it. So um, I never built more than about a half-time practice on my own during those years. The rest of my time, I was working in other people's offices. I worked with neurologists, and I worked with physiatrists, and I worked with family practitioners and chiropractors and podiatrists and, anybody who was interested. And I saw their patients. So what I got out of that was a real education in how people fall through the system, the cracks in the system, how people were being mistreated, misread, misdiagnosed, and completely screwed over so that they would go years without proper treatment. And many of those people I could help. Some of them I couldn't. But the point was that I decided that if I was no longer the referral of last resort and I could, be part of the medical club, that maybe I would get to help more of these people higher up the chain. In 1993, there was an article by David Eisenberg in the New England Journal saying, are you aware that people are willing to spend more out of pocket for their services, even if they're not covered by insurance, because they believe in this alternative stuff? You need to know about this. And so the timing I thought was perfect. If I go to school now, I'll not only get a doctorate, but I'll be in a position to join a faculty where I can teach a whole generation of osteopathic acupuncturists, let's say. And that turned out to be a total dead end because the schools were only concerned with proving that they were as good as any other medical school. So they weren't interested in branching out. That was just a non-starter as far as that was concerned. That was all right. I've never been much of an institutional person anyway. So I went to school, but before I even got there, I was in the anesthesiology office and I went on a skiing trip, tore up my knee. After 4 months, I still couldn't straighten my knee and I still couldn't squat. So the doctor asked me if I wanted to let him do prolotherapy on my knee. I said, what's that? And he said, oh, he's going to inject deep into your knee. And I'm like, I don't know, give me some more time. But eventually I let him do it. And after I let him do it, 5 days later, I was jumping plyometrically from the floor. So I knew there was something special there. And I thought, oh, this is why I'm going to medical school, because now I'm going to have licensure that'll allow me to do this for people. And this is one of the places where my acupuncture has kind of not been enough to get people over the hump. So definitely want to do this. So went to school knowing that I wanted to do physical medicine, knowing that I wanted to do prolotherapy. And my wife was in Connecticut. Her family was in Connecticut. And we came back here for Christmas. And I contacted one of their family friends who was a physiatrist in the area and asked if I could do kind of an interview with him. And I said, look, I know we're coming back to Connecticut to live because I promised my wife we would do that. He said, well, I'd be happy to have you. What are you interested in doing? I said, I want to do prolotherapy. He said, oh, like the guy across town, Larry Cohen? I said, who's that? So immediately called Larry Cohen's office, asked him if I could do a month with him. And he said, sure. I said, listen, I hope you don't mind, but we want to live in Connecticut. So if I'm in your office for a month, would you mind if I use your office as a base to make some phone calls? This was before cell. So he said, sure, happy to have you do that. He says, who knows, maybe we'll have something for you here. So I show up in his office on Thursday morning. By Friday afternoon, we knew it was going to work, and it was a great operation. But along the way, I still hadn't graduated. So along the way, he asked me if I had ever used homeopathics along with my acupuncture. I said, no, I haven't done that. So he said, well, that's something that I do in my practice. You might want to get familiar with that, especially as it applies to neural therapy. And I said, great, let's explore. So from the very beginning, we were not only using muscle testing, not only applying that to neural therapy, but also using the homeopathics with it. And that just made for another major leap in my integration. So took some neural therapy courses. He had already done all of the Klinghardt courses. And so I got some from Klinghardt and got a lot just by working on the job. That answers your question. I mean, that's set the stage for the next 20 years. So it's been a very interesting ride. And when I finally got Robert Kidd's book, I thought, aha, we finally have a neurotherapy book in English. I like this guy. I like this book. So I checked him out. I saw he had this whole blog of material that went back years already. And I saw he was teaching a seminar. So I emailed him, and we corresponded. But I had never met him until the conference in Ottawa. So went up to him and introduced myself, and he goes, "Oh, you're the guy, okay." So at the end of that conference, there was a meeting to to decide whether we thought that there was any value in building a neural therapy academy or organization. So I was interested. I showed up, and at the meeting, he says, "Well, no matter what we do, I want to make sure that we get Perry involved in this." I was like, wow, I felt very special. So that was what began the relationship with the academy. And then, from there, we tried to build it as best we can. And here we are. But it's been really rewarding, I think, because not only do I no longer feel alone, I left out that guy that I really loved, Larry, died a year after I joined his practice. So I had to make a decision about what I was going to do. So once again, I went out on my own. So it was great to have colleagues, and it was great that those colleagues were international. And I really feel that the neurotherapy family is a special one because most everybody who has gotten there has built several layers of integration in order to start doing that. I don't think it's absolutely necessary to do that, as you probably know. You can approach this from a totally Western perspective. You can say, well, we know the nervous system and we know the ganglia are here and we know we can shoot the ganglia with anesthetic and that's going to make a difference and you can track that. But if you have the other layers of sophistication, it only enriches the process. So the fun then is to reach all of these other people who get their lights turned on when you start talking about levels of integration that are new to them. We don't ever stop growing. So that's the next graduation is still ahead.
So you were doing both prolotherapy and neural therapy with this doctor? Yeah. When do you decide when to use prolotherapy or to use neural therapy? And can you tell us your thought process around the differences between them?
Neural therapy will create a change, as you know, in the connective tissue by virtue of turning off the signal. And sometimes that can be curative. But when you have an injury, when you have ligament damage or tendinosis or tendonitis, that doesn't generally heal as well, or it just takes so much longer when you're using neurotherapy or you're using acupuncture or massage, magnets, lasers. There are so many ways to affect the connective tissue, right? Um, and healing can take place with any one of them. But prolotherapy is so much more efficient with regard to that healing process because it organizes the entire system around that one area. So if I anesthetize something, I'll use that as a diagnostic procedure. I'll say to someone, let's say they've got, what they call sciatic pain, something going down the leg. Now, I have to discern, is that a trigger point in the gluteus minimus? Is that a ligament weakness at the iliolumbar ligament? Is that a failure at the ischial origin of the hamstring? Is it a peroneal problem? Is it something going underneath the foot? And all of those things can be possible. So, of course, the muscle testing gives me a tremendous opportunity to find the spot where the nervous system is struggling the most get in there, and then we can start. I will even do this because I told you I muscle tested my socks. I mean, I'll take a bottle of dextrose, I'll bring it into the field, and I'll ask, is this the way to go? And sometimes it's not. So then, okay. So then I'll try the ozone. I'll fill a syringe with ozone, bring it into the field. Is this the way to go? No. Okay. Then do I really have to use cortisone? Pull the cortisone over. No. Okay. And now back up. Did I do the wrong thing? Is there another place that I'm supposed to be treating before I get to this one? What is going on? And then I'll find out, okay. And this happens often, by the way. I will also bring the procaine into the field, and I might get a no with that. That's when the homeopathics come out. So pull the box of homeopathics, and then I'll go through the vials almost like using myself as like a personal Vega tester, where I've got a matrix of stuff. I'm looking to make a connection that solidifies the nervous system. And then I'll say, okay, so I see. I'm supposed to use a Sanum remedy. What's the Sanum remedy for? Oh my God, this is a Sanum remedy for fungus? What's that about? And then, oh, I've got really bad candida. And that's when I'll say, okay. So the reason why the system isn't healing because of the inflammation from the candida. Now, if we use that, now that opens up. So then after I do that, I might find now my prolotherapy is appropriate. Does that make sense? Like everything is about prioritization. And that really is the key as far as I'm concerned, because I don't want to overstep in my zealotry. I don't want to do something to the patient that is not appropriate. So I need to find out what they want. So there is a prioritization that I do, and there are many ways to do this, but the way that I do it is once I find a lesion, let's call it, a weak spot, something that throws the nervous system off, an interference field, let's call it. Then I want to find out, is this appropriate for me to treat? So I'll ask the patient, hold your breath. Do you guys do this? Okay.
Mm-mm.
So hold your breath, because when you send a signal from your frontal lobes to your arm, let's say we're using arm as a tester, then that's a downgoing signal, right? When I touch an irritated spot, let's say on the sacroiliac, then that sends a disturbance signal up the spinal cord going the opposite direction. So in as much as that interference field now produces a strong signal, that partially inhibits my downgoing signal, and that makes my initial resistance falter. That's muscle testing, okay? Now I'll ask them to hold their breath. Holding your breath now makes you use additional information from the voluntary centers, enhancing the downgoing signal to the arm. So my interpretation is, if they hold their breath and where they're formerly weak, now they're strong. That means, oh, if they just put their mind to it, then it's not such a big deal. And what that means to me is I can go there safely. It doesn't mean it's the most important of the interference fields. It means that if I do it, I'm not going to blow them out of the water. So it creates a degree of safety to my treatment that really makes me feel much more confident about moving forward.
So you do the hold the breath thing with each question that you're asking, or with each.
When I reach an interference field, I'm sorry,
Mhm.
what?
With each. So you do the hold the breath which with each question that you're asking the body.
No, when I find an interference field, I will ask, hold the breath. Now, what's interesting about that is that there may be quite a few interference fields that are not going to create too much trouble. So as soon as I find one, I can move ahead and then find the next one. But I do often find them, because if someone has a very big, obvious problem, and I go to that spot and it says, no, don't treat me. And I mean, this is how I interpret the information, because if they're still weak after I have them hold their breath, I interpret that to mean, even if I put my mind to this, I can't overcome this signal. I can't be strong. So I then take that to mean, leave that alone for now. There are other things that I can do that will allow me to get to this spot. And often we do, most of the time.
So a patient comes in, a brand new patient comes in, and most people are finding you for chronic pain, right? That's your specialization.
I think that's fair. Yeah.
Okay, so a patient comes in with some kind of chronic pain, and you're, taking the history, doing a really good clinical intake to see what's happening, and then you get them on the table and you start testing. And your thought process is this caused by some kind of lesion? Is this caused by some kind of inflammatory process? Is this caused by an interference field? Is that how your thinking is working as you're treating patients?
All right, so I do have certain biases, and I share this with patients, sometimes very upfront and frankly. I'll say, look, I'm an osteopath, so I have a bias toward the structure, and I'm going to try to treat the structure as deeply as I possibly can. Now, we know from your x-rays that you don't have broken bones, so the next level up is going to be the ligaments. And if the ligaments are not strong, then they're going to place the burden of holding your bones together on your muscles. Most of the time, your pain is generated from your muscles. And then, of course, I'll do the appropriate tests, to make sure that it's not a nerve related thing. As I said, like before, they say, I've got sciatica. And I think, yeah, okay, we'll find out. So we get them on the table and they're sitting on the table. I'll straighten their leg out in front of them, stretching the sciatic nerve, and they don't bat an eyelash. I said, well, guess what? We just stretched your sciatic nerve and it didn't bother you. So I'm starting to think differently. Maybe it's not a nerve root problem. Okay. And it'll also be dictated by, the presentation. They'll say, oh, I've got this pain that goes down the side of my leg all the way to my ankle. And I'll say, okay, so it doesn't go onto your foot? No. Does it cross over from from the lateral side of your thigh to the medial part of your leg, which would be consistent with like an L4 level? No. So if it doesn't go into your foot, that means it's probably not an L5. If it doesn't cross your leg, it's probably not an L4. So we have to find out what the pattern is. So we're now working our way through this. And I don't just believe me, I would love it if someone could walk through the door and I would just kind of size them up and go, I know what I'm going to do. I know what your problem is. But the reason why I go through this whole protocol and I'm kind of anal about it is because I don't want to assume that I know enough to figure out what that person needs. They've got to tell me. It's hubris to think I know what I'm doing, and because that's going to backfire somewhere.
Can you give us a patient case? People love cases. Can you give us an example, like a patient case that walked in where you use this protocol and landed on a neural therapy treatment because of X, Y, and Z?
Yeah, I could give you tons of them.
What's your favorite?
Well, I was reminded of this because I this lady came in a couple weeks ago and I hadn't seen her in a while. And we were working on, you know, her lower back or something like that. And then she reminded me that the reason why she had come back was because initially she had these horrible headaches. She had had an acoustic neuroma removed. So she had, a C-shaped surgical scar opening up her skull. And of course, as a neurotherapist, I said, well, let's take a look at your scar and see what's going on there. So I treated her scar from the neuroma and, 9 months of daily headaches subsided. I would say probably 60% on the first treatment, another 20% on the second treatment, and then by 3, it was gone. So, that's a perfect neurotherapy story. There's another one. I had a young boy. Oh, this is one of my favorites. Okay. This woman had vulvar pain. And, as a man working as a practitioner, it's a little bit dicey, because you need to be quite careful about how you're examining this woman and how to approach the whole thing. Um, I hope I'm remembering all of this correctly. Suffice to say that she came in always with her new husband. She was like 70. She came in with her new husband, and they had moved from Florida up to Connecticut uh, fairly recently. And as we're taking the history, she told me she had 3 sons. And I said, oh, okay, so where do they live? They live in Florida. And then she starts crying. She hasn't talked to 2 of the 3 in 10 years. And this is eating away at her. So as I did find interference fields, and I did find them in her genital region. But the key to this whole story is that it wasn't necessarily about finding the interference field at the physical level, because her whole thing was about how she had been abandoned by her sons because her former husband had poisoned her sons' minds about her. So of course the connection that she had to them, she had birthed these kids. And so physically, it showed up in the place where she was most vulnerable in her connection with. So once we had established that and we worked through the appropriate interference field, treatment with some kind of Bach flower remedy, if I remember correctly, it disappeared. So good stuff.
Yeah.
There was a kid who was maybe 7 years old at the time. I had been treating his mother for years already before that. And he had all kinds of problems. He was, trouble at school, kind of an ADD kid. And one of his biggest problems was he couldn't hold his urine. He had to go to the bathroom frequently, like twice an hour. Every half hour, he's asking the teacher, "Can I go? Can I go?" And of course, this is a nuisance. It's interrupting class. And so they said he can't go to a regular school. He's got to go to a special school. And, she brought me in to evaluate him. And I lifted this kid's legs and, it was almost like the Brzezinski. Does that mean anything to you? Okay. So I thought, oh my God, does this kid have meningitis? I don't know. He needs to be seen. So long story short, turns out he had a tethered cord. And that was leading to the urinary problems and his anxiety and a lot of his inflexibility. So he gets this fancy surgery, get rid of the cord tethering, and still makes no difference in his urinary. So they put him on Ditropan and then Norbetric, which was not approved for kids at the time. I don't think it is even now. But they were desperate. We need to do something to keep this kid under control. So she brought him to me, and I said, "Oh, of course, the surgical scar was messed up. Treat the scar." And problems went away. These are sort of like the magical things that happen, and it's not always like that, but so often, as you know, fairly simple treatment of interference fields can yield tremendous results, things that you wouldn't otherwise expect. And it's so easy. If there's a message to convey to, the people who are watching your podcast, I think the thing is that you can enter neural therapy at any level. If you never do anything more than checking people's scars and treating them, you're still going to help tons of people and many more than you would otherwise, right? And if you're a Western guy or gal and you are thinking this stuff is bullshit, I don't really understand any of this energy stuff, I'm not going to go around muscle testing my patients. If you can still get that we have nerves, and the nerves have nerve endings, and those nerve endings are interrupted when you cut the connective tissue. And if you restore that electrical relationship, good things can happen. So you don't have to be woo-woo in order to embrace the idea of using an anesthetic to help rectify a dysfunction in the system. That all by itself means that we can reach those people, and we don't have to convert them in order to allow for greater outcomes for a large portion of their patient population. Right? That is the best. So this was the story that I started telling you. Like, when I started my practice, I wanted everybody to learn the stuff that I had been learning. And it was such a big mistake because all they wanted was their pain gone. So I learned, okay, you have to meet people where they are. I don't want to convert some anesthesiologist into, doing acupuncture. That's not the point. The point is to meet them where they are and say, hey, you use these things all the time. Have you ever thought about treating one of those surgical scars, after the orthopedic surgeon's done with them? It just makes so much sense. So the next step, I guess, for me is I've been working through the University of New England, which is my alma mater, to get continuing education. I think I need some water. Continuing education credits for our workshops, and it's gone very, very well. Now I think what we need to do, or what I need to do, is to start teaching these workshops for the medical community and getting them on board at whatever level. I just put in an application for the Massachusetts Osteopathic Medical Society to speak at their next thing next fall. I don't know whether they want it or not, but if they do, then that'll be an opportunity to reach some people who otherwise would never be in our camp. So it's fun.
Yeah, I think I totally agree with everything that you're saying in terms of I've seen so many patients that I'm like, God, if only this scar would have been treated after surgery. And people have been in pain for like a year, 5 years, 10 years. I'm like, why can't we just have this be a part of medicine? And then they're not going to be falling apart and ending up in my office, So yeah, even just doing the scars, and that's something that Alana and I teach in our classes is like, especially at the end of like 2 days of doing tons of injections, and people are like overwhelmed. And
Yeah.
we just say, if you just do scars, you are going to help so many people. Yeah.
Yeah, not everyone has to do a Frankenhauser. Not everyone has to do a stellate ganglion. Like it's one of these things that I think is really important because we've kind of shied away as a group from doing this idea of certifying people as neural therapists. I think that's sort of a I don't think it's a great idea for us because we're all on a learning track. We are all trying to integrate these things, and I don't believe that it's good for us to suggest what is or who is a qualified neurotherapist because, as you know, someone with talent can be given a little bit of teaching and they can really run with it. And someone who's not talented can be certified up the wazoo and they still are just no more than proficient. They're not and that happens at every level of education. So, who am I to say what makes for a qualified therapist? But what we can do is we could say to these people, all right, this is our introductory course. You've taken our introductory course. This is our secondary course. And then they could advertise, well, I've taken 6 neurotherapy courses. So I generally don't do those deep injections. And that's another thing I think is worth saying. Since we're working with a connective tissue matrix, you were asking, when do you use prolotherapy? When do you use neural therapy? Your intention is far more important than the needle that you're using, than the anesthetic that you're using. Is it better to use lidocaine or procaine than lidocaine? Is it, well, in my mind, yes, it is. And do I try to get procaine? Yes, I do. But if I don't have any and someone needs neurotherapy, I'll use lidocaine because that's what I've got. And the intention is far more important. So some people are intimidated about doing, let's say, sphenopalatine ganglion from out here. Once you get the nerve and you've done a few of them, it gets easier. But doing that first one's it's a pretty big barrier, right? You don't have to go in to here if you've got the intention of getting inside and you still get it from here because the connective tissue will take you there. Your intention will be registered in the electromagnetic field through that connective tissue, and there will be a change. Would it be as powerful or as long lasting? I can't say that. But I can say that the focus of the intention is critical to the result of the treatment. And that's in any endeavor. So I'll notice, for instance, if I've got my hands on somebody, I could be daydreaming and thinking about, the football game tomorrow or, something like that. But I'll sometimes catch myself if I got my hands, let's say, under the occiput for someone. I'll say, wait a minute, why are you here? What's our purpose? And then I'll do one of two things. Either I'll be searching for the connection through my hands to the vortex inside the system that I'm trying to work with, or I will simply call in the vortex through my body and exhale the light through my fingers and let the light go where it needs to go. I'm making sense, right? Okay.
To us woo people, yes.
To the woo people, I'm still, at least I can count on you guys. But the point is, the intention is there. And wait, just one more thing. And could I be more specific with my intention? Well, if I have a sense of where the vortex is and I bring the light through, then I can focus even better with my hands and do a better job. So what I'm saying is my treatment is going to have some effect no matter what, in the same way that putting a shot of procaine in here is going to have an effect. And if my intention is there, the effect is going to be that much better.
So you're still pairing osteopathic manipulation therapy with the prolo, with the neural,
Oh yeah.
with the ozone.
Oh, definitely. Yeah. I mean,
And they get a little bit of each, or you kind of have osteopathic treatments and injection treatments and
yeah, they're not exclusive. No, I will in a single patient encounter, they will very likely get 3 out of the 4. They'll have a manual treatment, trigger point therapies, acupuncture, which and there's a lot of overlap there too. Neural therapy and manual treatment is different depending on how what you're doing, right? Because if I'm doing cranial work, again, I am waiting for I'm sitting back, you see me sitting back. I'm waiting for the system to tell me what to do. Whereas if I'm doing a high velocity maneuver, which I seldom do, but just by contrast, to say, if I think, well, this bone is clearly out of place, we just have to put it back in there. So there are levels of treatment that are integrated through everyone. So yeah, I do all of them, and very often multiples in the same patient.
Perry, to what you were saying previously, because I do osteopathy cranial as well. One of the things I noticed, because I started studying it before I went to medical school, so I had I look at my notes. I still have my notes from my first class, and I did not know how to spell anything anatomic wise, like bulks and tentorium and all that stuff. And what I realized is when I went through medical school and actually had like much more training in anatomy, and looking at cadavers and tracing nerves, that my palpation skills got so much better. Like I felt like I could have a greater effect. And I think it's exactly what you're saying. It's that intention, because now it's like I know what's in there. I know what it should feel like, because it's got this shape and this sort of texture to the tissue. And so, yeah, I think that's really neat. So that's what I'm just, wanted to add that.
Yeah, that's really interesting. So if there's time for a political statement here, in the world of cranial osteopathy, there is a great deal of disdain for John Upledger because they have this sense that, as you said, the more you study, the more you're able to manage the approach to treatment with finesse. And so there's a local guy here who's a major teacher in the cranial academy, and he just always gets disgusted. He says, you must have seen one of those craniosacral people. He says, oh, they got locked up and now I have to free this stuff up. And as I said before, someone who's got talent will be able to fly with it. So there is no rule that says you have to be a medical doctor to have good hands, and there's also no rule that says that you have to be a medical doctor to have a compassionate approach to treating people. In fact, I think maybe there's an inverse relationship, that if if someone is a massage therapist and they learned something about cranial work, yeah, they may not have the same sophistication when it comes to working with the tissues, but if they have the compassion, they're 90% of the way there.
Mm-hmm. Yeah.
So um, so I take exception to the conceit of the osteopaths who think that no one else can do this job. And part of it is that they feel that he kind of gave away the keys to the kingdom because it had taken years of study for them to approach this level of sophistication with their treatment. And here are these people who never went to medical school, and how do they think that they can do this work? So I saw that in acupuncture school too. It was like they were begging the medical doctors to accept them, but then the medical doctors who were sympathetic to acupuncture and wanted to learn it themselves, they said, "Oh no, you can't do that. We did 3,000 hours of training. You can't do it with 200." And the doctors would say, "Yeah, but we're doctors." And then say, "No, you don't understand. Yeah, anybody can stick a needle in, but are you doing it with sophistication?" So there's always this turf building and boundary crossing that comes up. So now the physical therapists want to do, dry needling, right? And they say, oh, we know enough to do that. And then the acupuncturists say, no, you're doing acupuncture. Well, we're not. We're doing trigger points. And we can do it with acupuncture needles because we know what we're doing. And so it's all fight for turf and money,
Mm-hmm.
you know, and and bragging rights, or whatever it is that people hang on to. My feeling is a healer is a healer is a healer. And if if you if you add techniques to your armamentarium, then you just have more. But it's the intention, it's the compassion, it is that allows for all that other stuff to be useful. You can train a monkey to do, and now we're training computers to be doctors, right? So it will not surprise me if half a dozen years from now, most primary care visits will be handled by computer because we don't have the personnel, and people are sick, literally sick, but often sick and tired of uh, not being able to get to their primary care doctor. They call up and they say, "Oh yeah, we'll set an appointment. We have a 2:30 on May 17th." And they're like, "Wait, it's January." I can't wait until May. The reason I called up is because I had a problem now. So, oh, well, sorry, we just don't have any time. So now people go to the portal and the computer will ask them, oh, do you have a fever? Is your throat sore? And it'll do triage and it'll say, okay, so if you're not better by tomorrow, make an appointment or something else. It'll prescribe, it'll tell people what to do. And it might do a better job in some cases. Say, I, I
Some of the
see,
studies were saying that, yes.
yeah, I see you're on a statin drug and your liver enzymes are going up. I think maybe we should take let's take your dose down a little bit, see if that would work. That can be done by a computer. You don't need any compassion for that. So I don't have a lot of hope for that in the immediate future. But what's happening now is we've got, a medical revolution of sorts on the verge of tipping, right? I have no idea how far they're going to let, Robert Kennedy or these other folks get with actually changing laws. But there will certainly be some very interesting discussions coming up in the near future. One thing we can count on is it's going to be an interesting and bumpy ride.
This is true.
Perry, do you have like a favorite injection that you pull on again and again? Like that's like you have the best relationship of predicting what that injection is going to do. Just out of curiosity. No. Okay.
No, absolutely not. Yeah, maybe what you're fishing for is because I have heard people say like, "Oh, I do stellate ganglion all the time," something like that. And no, I don't know if you were on the call with David Vignes last week. Did you see that one? I thought what he had to say was interesting. Said, I used to look for deep ganglia and that kind of thing. I would often start off with a stellate injection because it would get my patients to a place where they would be more relaxed and so on. He says, now I palpate. Now I just put my hands on, I find a point of tension, go there. Find another point of tension, go there. And by the time I have gotten through my superficial palpation, we're a long way into the treatment. Then we can move from there. So, of course, there are many different approaches. And what I just shared with you, as far as I know, is idiosyncratic. I have arrived at this through many, many trials on my own, but I absolutely do not have a favorite injection. It just doesn't work that way because of what I said about asking the body what it wants or what it needs, because everybody's different. Is it true that there are some injections that tend to produce wonderful results? Yeah, that happens all the time. But I can't predict, and I don't have one where I say, oh, this is my go-to. I always do this. Wait till you see this. And that doesn't work that way.
Can we shift gears really quick? You've been on the board of the NANT for a long time now, and you guys have everybody elected a new board in this last year. Where do you see what are the next goals of the organization, or where are you guys going to take things next?
Richard Nahas is very interested in focusing on the idea of the interference field as a point of contact for any number of medically oriented folks. So that means he is opening the door, just exactly the opposite of what I was saying. Instead of making this an exclusive club, he wants to make sure that that acupuncturists and massage therapists and physical therapists and other people who are simply trying to learn have access to this information. And, even if those people don't have licenses to inject, they still can make use of the information. It's still very valuable. So that's the immediate goal, is to start outreach by making contact with other organizations and doing exactly what you're doing, just getting more people with eyeballs to watch what we're doing. So that, I would say that's where we're headed right now. And Richard is still interested in making sure that we stay connected with the international organizations. So IFMANT, which is as you know, is the international foundation and is based in Europe, is quite interested in making sure that we are part of their group. The Latin American folks have been very welcoming, but the issue there is language. So I've noticed that their approach is more like ours, and that came from the teaching of Dr. Payan in Colombia. So a lot of his students are now doing the teaching, and they are more aligned with us in terms of practice and very well organized. They're doing a lot of teaching. As you know, they have a master's degree, which is postdoctoral. And there's a new one that will start this year in Argentina. I'm sure that Jorge told you about that.
They're even teaching nurses, which I thought was great to get more people doing this work. Yeah.
Right, because they're considering this an academic degree. That's where I think it's, again, quite consistent. If you give people a curriculum that helps them to understand this work, then they can do with it what they wish. I mean, you go to medical school and some people end up as anesthesiologists and some people end up as psychiatrists and some people end up as family practitioners. They all got the same basic education. It's what they do with it. So yeah, I think it's great um, that they are doing that. I'm sure that as we go, I mean, now you can buy these glasses that will do instantaneous interpretation. There's no need for us to have language as a barrier anymore. So I think that we can continue to build. Do you know the glasses that I'm talking about?
I've heard a little bit about them.
They're like,
I know you can do it on your iPhone, so it makes sense to me that they would just put it in the glasses because can you just see what they're saying in the glasses?
if you look at your phone, you can see it on text, and then it'll speak to you in your language on the ear. And the glasses are $17.
Wow.
So again, things are changing. Like if we can just keep the earth spinning for another 15 years, it's going to be so different. Like we couldn't have understood in the year 2000 that by 2015 everybody was going to be walking around with one of these things in their hands.
Yeah.
But now they're indispensable. You can't do it. You can't even open your computer without a password from your phone. I mean, I can't. I can't open up my medical records without a password from my phone. So if my phone goes dead, I have to, I'm sent back to 1973. I mean, it's just, and by the way, I'm comfortable with 1973 because I lived it, but there are a lot of people who aren't, and they don't know how to do that.
Yeah.
That's frightening.
Any other questions, Alana?
Just Perry, can you tell everybody how to find you, like where to track you down?
In my basement. I do actually practice out of my house. And so I'm in Reading, Connecticut. I do have a website. It's a terrible website. We've been asking my sons to help us
1973.
build a new one. But, the basic information is there, and it's called advancedpainsolution.com. And they can call me if they want. I think the phone number is on the site,
I hope so,
203.
Perry. If it's
What's
not,
that?
you've got way bigger problems.
Do you have
But yeah,
teaching or anything coming up, Perry? Are you going to be speaking at any conferences about neural therapy or your injection?
I just mentioned that next fall I'm hoping to do this Massachusetts osteopathic thing,
Great. I hope that works.
and I think that'll be fun. I have been asked a number of times to organize a muscle testing workshop, and I, I don't have anything on the schedule, but I've done that. It's really interesting because I've done that with people who are not medical, and they love it. So, it's almost better to rid yourself of any left brain biases to start the process. And those people who don't have medical degrees are way ahead of the game in a lot of those cases. So yes, I mean,
I've had a lot of patients want to take my cranial classes throughout the years. So that's been great. I've loved that.
that's very interesting.
Yeah.
I'm glad you did that.
Thank
So
you.
we seem to be at an end, right?
We are very, very grateful for A, your time, and B, your dedication to the field and spreading this very valuable information, because I know all of us, neural therapy moved the needle for our practices in ways that other things didn't. So we just
That's
want to
great.
say thank you, and we really appreciate you coming on and talking to us about it.
Of course. And, you are the ones who are spreading the word. I'm just saying the word.
You're very good at saying the word.
Okay, thank you everyone for joining us for another episode of the Point of Medicine podcast. Thanks for joining us today. If you like the episode, please like and subscribe to our channel and review us on your podcast players. Also, if you think this episode is helpful to some of your friends or colleagues, please share it widely. If you are curious about learning about neural therapy or other injection techniques, check out our courses on learnneuraltherapy.com. We'll see you next month for our next installment of the Point of Medicine podcast.